So next up is Dr. Rolando Clor del Granado, and he's going to speak to us on urinary microscopy to identify subclinical AKI.
Okay. I want to thank Ravi and the organizing committee for having me here. So I'm going to show some data we have about the use of urinary microscopy as a biomarker in order to identify subclinical AKI. Well, it's well known that tubular damage without glomerular function loss has demonstrated to be associated with worse renal and overall outcomes. The third subclinical AKI that has been introduced more than 10 years ago has challenged the traditional view that only the problem is clinically relevant when you have a loss of your kidney function and before any damage becomes apparent. So now AKI diagnosis should include functional criteria and also damage criteria, and subclinical AKI has shown that has an important impact and could have an important impact in the way epidemiology is shown in terms of prevention and in terms also in the way we manage patients with AKI. So there are some done studies about classifying AKI into this new stage, like this, for example, where they use NGAL and they show that patients with this biomarker that was positive, but they didn't have any rise in serum creatinine or decrease in urine output, had a higher risk of renal replacement therapy requirement, a higher hospital and ICU stays, and also a higher increased risk of composite outcomes. This also has been shown in AKI related to COVID-19 patients. In this study, they used KIM-1 and Vit2 microglobulin to diagnose subclinical AKI. And as you could see, patients with subclinical AKI has an increased risk of subsequent clinical AKI and subsequent development of acute kidney disease, CKD progression, or de novo CKD. AKI has proposed to move from this current diagnosis AKI criteria that only takes into account serum creatinine and urine output to a more expanded diagnosis AKI criteria, where you have 3 stages in stage 1. That will be 1S, who is subclinical AKI. That's when you have a biomarker positive, but there is no increase in serum creatinine and no decrease in your urine output. As well, stage 1A will become when you have a biomarker negative, but either you have an increase in your serum creatinine or a decrease in your urine output. And finally, stage 1B is when you are biomarker positive and either you have an increase in serum creatinine or a decrease in your urine output. So biomarkers could help us to achieve this important goal of improving AKI management and prognosis, etc., and they definitely will play a significant role in the diagnosis of subclinical AKI. What about the urine microscopy as a biomarker? Most of these scores that were developed with a standardized form of processing your urine samples were developed to predict non-recovery from AKI, AKI progression, and for differentiate between pre-renal AKI from ATN using just 2 things, looking at renal tubular epithelial cells and granular casts. So in order to identify patients who will benefit from this, from using this urine microscopy score, we use this approach, this algorithm that is from Lilia Rizzo, that's called the Nephrology Rapid Response Team, and the 4 Fantastics. The 4 Fantastics are composed by the actual clinical scenario that every patient has, past medical history, laboratory results, and physical examination. So if you have one of these items, you are on moderate risk. You have 2 or more items, you will be in high risk. And that triggers an electronic alert and a rapid response of a nephrology team who will start a bundle of care and also a follow-up after this electronic alert takes place. So was our study flow chart. Every patient who was enrolled in the study, we have 103 patients that were enrolled in the study, go through this risk evaluation, and if they have moderate to high risk as assessed by this risk score algorithm, then they will go through urine microscopy analysis. So the urine sediment score was assessed at hospital admission, then at 48 hours and at 7 days. Also, we follow up serum creatinine and urine output, and we classified patients into different AKI stages. So this is the score we used. That's the score that was developed by Peracella, that only takes into account the number of granular cast and renal tubular epithelial cells. For example, you get a score of 2 if you have between 0 renal tubular cells and 1 to 5 granular cast, or if you have between 1 to 5 renal tubular epithelial cells and 0 granular casts. These are the baseline characteristics of our patients. Most of them have 2 or more risk factors for developing AKI. Most common causes of AKI were sepsis, hypovolemia, hypotension, and the use of nephrotoxins include the traditional medicine. Most of the patients were female. We were able to get a baseline serum creatinine in all of them because they were usually seen before by family physicians in the social security system we have in Bolivia. The baseline creatinine was 0.9, and the admission serum creatinine was 1. So in terms of subclinical AKI, 39 patients, that is 37.9% of the patients, have subclinical AKI. That means that they have an urinary sediment score equal or higher than 2 points. And during the follow-up, 48 hours, 31 of these 39 patients develop clinical AKI. That's almost 80% of the patients. If you compare to just 11% of the patients who at their admission they have no AKI, that subsequently develop clinical AKI by KDIGO guidelines criteria. By day 7, from the patients who at the admission did not develop AKI, who have a normal urine sediment score or a score that was lower than 1, only 7.9% developed clinical AKI in different KDIGO criteria stages. And as compared of 70% of patients who had subclinical AKI and later developed clinical AKI. So during the follow-up period of the whole study, during the 7 days, patients who at admission did not have subclinical AKI, only 17.2% developed clinical AKI. If you compare with the percentage of patients who have a urinary sediment score equal to 2 or higher, 92.3% of these patients develop clinical AKI during the follow-up. So a score of a urinary sediment score equal or higher than 2 at admission had a good performance in predicting clinical AKI with an ROC AUC of 0.84. And in terms of renal replacement therapy requirement, patients with subclinical AKI, 10% of them require renal replacement therapy during the follow-up. If you compare with patients who at admission did not have acute kidney injury, only 1.6% require AKI in the following 7 days, once they develop clinical AKI in the next 7 days. In terms of mortality, patients with subclinical AKI have a mortality of 43.6%, and it was much higher than patients who at admission did not develop AKI, but subsequently developed clinical AKI at advanced stages that were 14.6%. So in conclusions, subclinical AKI is still AKI. Urinary sediment score can identify this early phase of AKI. Urinary sediment score could become an extremely useful tool to refine our diagnosis and staging AKI criteria, especially in low resource settings. And patients with subclinical AKI had a higher risk of developing clinical AKI, a higher need of renal replacement therapy, and finally higher mortality. Thank you for your attention.